So I'm going to talk about a robotic pyeloplasty, which is an operation we do when the drainage of the kidney is not as good as it should be. So the kidney is an important organ to filter the blood and get rid of toxins, and also make sure that we've got the right amount of fluid in our body. Most people have two kidneys, and sometimes the drainage of one of these can be affected. One of the conditions that can affect the drainage of a kidney is called a PUJ obstruction, which stands for pelvic-ureteric junction obstruction. And that junction is between just the top of the kidney where it drains and the tube that drains all the way down to the bladder. So there's usually a narrowing at the top of that tube, and that narrowing is normally present from birth. It's usually due to just some muscle that's not relaxing as well as it should do. Interestingly, a lot of people early on in life have no symptoms from the PUJ obstruction, but at some point during life this can cause more problems, more blockage, and then it starts to cause pain. It doesn't always cause pain, so sometimes we find out that someone has got a blockage to the kidney because they've had a scan and that's shown some swelling in the kidney, the swelling being the urine that can't escape because it's not draining as well as it should do. If you do have a narrowing called a PUJ obstruction and you get symptoms, then the most common symptoms are pain in the kidney area. The kidney sits in the back, just underneath the ribs, called the loin area. And that pain's often when there's more flow of urine through the kidney, therefore trying to get through this blocked area. The times when there's more fluid going through is normally when you've drunk a lot of fluid. Often if people have had alcohol, because that pushes more fluid through that area, and that can produce pain. If you imagine you've got an area of urine that can't drain from the kidney, it's also at risk of infection. So sometimes you might develop an infection with pain in that area specifically. If we did nothing, then the pain normally doesn't go away, and the kidney can deteriorate because it's been blocked and therefore the drainage hasn't been as good as it should be. If we were to do something to try and improve the problem, then there are a number of options. We can either put in a tube into the kidney itself to try and improve the drainage, but obviously that then becomes a permanent situation, and that tube can sometimes stick out the side of the back to drain the urine. The tube can go internally down into the bladder, but again, this is not a permanent solution. If we wanted to try and improve the drainage with an operation, which is the other alternative, then there are two options. We can either put a camera on the inside and laser the narrowing, called an endopyelotomy, but this only has around a 70% chance of being successful. And the other option is a robotic pyeloplasty, which is what this video is about. So a pyeloplasty involves cutting out the narrow area and then rejoining the tube back onto the kidney. We just need to widen the tube a little bit when we do that, and the diagram shows how we do that. We just spatulate it, as in just cut down the tube a bit to make it a bit wider and then join it all together. Because there's urine involved, the urine can leak out any small hole in the joint, so we tend to put in a stent, which is a little tube that curls up in the kidney and curls up in the bladder, and it just helps the urine to drain without leaking out through the joint. The operation itself is a keyhole operation, so it means only small holes in your tummy, normally around 4 or 5. And we do this either without or with standard laparoscopy, which is just keyhole, or with something called the Da Vinci robot. The Da Vinci robot is a fantastic piece of technology, which means that we can put small holes in your tummy with small ports through those holes, and then we can introduce instruments through those ports that are held on by robotic arms. We can sit in a console and we put our head into a viewer. We have a picture inside you, and we can put our hands into small loops, and as we move our hands in those loops, it moves the instruments inside you. What this means is it's like having hands inside you, but only with small incisions where we have the robotic instruments going through. And it means that we can do very intricate surgery, such as cutting out of this narrow area of the PUJ and stitching up, which again is quite complicated if we're doing it through just straight instruments. It does mean that the recovery is usually better and the results are better. Normally the operation means just a one-night stay in hospital. It does take around 4 weeks to get over the operation. Normally during that time, it's just a bit uncomfortable moving around because of the small incisions. If we close those with dissolvable stitches, then they can take a few weeks to dissolve. Sometimes you might have skin staples, and if you do, then those are normally removed 10 days after the surgery. You'll have a catheter in after the operation, and normally that's removed the following day. You also normally have a drain in, and again, that's normally removed the following day. So normally around 4 weeks after the operation, you'll have the stent removed. This is done with a very fine camera put into the bladder under local anaesthetic in our outpatient department. So it's quite a minor procedure. It sounds awful, but it is certainly not as bad as it sounds. Most women that have had a smear will say that the smear is worse than having had the stent removed. So through the water pipe, we put some gel to numb the water pipe up, and then we put a very fine camera down the water pipe to get into the bladder. When we're in the bladder, we put a very fine instrument through that camera to hold the end of the stent, and then we pull the camera out, which pulls the stent out at the same time. The procedure only takes a few minutes and there's very minimal recovery from it. So you could resume pretty much completely normal activities the day after the stent is removed. At this point, the chance of being cured from the PUJ obstruction is very high, so about a 95% chance that you'll not need any further treatment, although we do tend to do a scan around 3 months after the operation called a renogram. You'll have normally had a renogram before the surgery to diagnose it, and this just confirms whether the operation has been successful. But it's highly likely that it will have been, and normally the symptoms will be the most important part of this. Therefore, if you're not experiencing any pain afterwards, then it's highly likely the procedure has worked. In terms of complications, then there are small risks of bleeding infection like any operation. You can leak urine from where the joints have been done, which is why we leave a drain afterwards. And if there is a leak of urine, then sometimes the drain is left a longer period of time, although that would be very, very rare. There are small chances of damage to surrounding structures, a very, very small chance of an open conversion if we run into difficulty with the operation. And the joint can narrow down in the future, but there's a less than 5% chance that this would happen. So overall, the procedure has minimal risks, and normally it would just be a one-night hospital stay. Before the operation, you will need a preoperative assessment appointment. This is just to check that you are fit enough for the procedure itself and to go through any investigations or issues that may arise. It would quite commonly involve a tracing of your heart and some blood tests, as well as a questionnaire. You may need some swabs before the operation, and if so, those will all be organised. On the day of surgery, you'll be admitted to the ward and you'll be seen by one of the nursing staff who will go through, again, important checklists. If a consent form hasn't already been completed, then this will need to be done, and you'll see the anaesthetist will go through all of the issues regarding the anaesthetic. It's normally a general anaesthetic, and there will be starving instructions. Normally you would be advised to starve for 6 hours before the operation and to only have clear fluids up to around 2 hours before the operation. On the day of surgery, after you've had all the checklists done, then you'll go down to the operation department and go into the reception, and then when further checklists are done, you'll go through to the anaesthetic room where the anaesthetic starts. Once that's complete, you'll come through to the operation room itself so that the procedure can begin.
I'm here to talk to you about wound care. After you are discharged from hospital, you will have some small dressings over your wound site. The nurse who's discharging you may give you some additional dressings to take home. You are expected to keep these in situ for at least 24 to 48 hours after your surgery. After that period, you are expected to take the dressings down. You can shower at that stage. Please do be mindful not to scrub the wounds, as this can cause irritation. Please be aware that within those first 24 to 48 hours, you may see a small discharge. That's an ooze coming from the wound site. However, this is normal and doesn't necessarily mean that there's any infection present. Please be aware when you shower, do not use any perfumed soaps or body washers, as this may irritate the area. Please avoid bathing for long periods, as this can cause irritation to the wound site and cause potential infection. Please be aware to avoid swimming for at least 4 weeks, as this can cause inflammation and swelling to the wounds initially as they are healing, but you should also restrain from doing any vigorous exercise after your surgery. Once you have taken your wound dressings down, you will notice you will have dissolvable sutures in situ or clips. The sutures normally dissolve after 2 weeks of their own accord. However, it can be slightly longer for some patients. If you have any concerns about this, please contact your specialist nurse key worker on the information provided. If you have metal clips in situ, these will generally be removed by a community nurse, which may be a district nurse or a practice nurse, within 7 to 14 days. If you have a drain in situ, please be aware that this area and this wound will take slightly longer to heal. The nurse who is discharging you may advise you to keep your dressings in this area for slightly longer, and please be aware to treat this as any normal cut and graze as you take the dressings off, exposed to the air to promote healing. I'm here to talk to you a little bit now about your drain, if you have one placed in during your operation. This is a very soft, hollow tube that promotes fluid and secretions from the wound site and is generally in situ overnight after your operation. The nurse will then assess this area along with the surgeons the next day. If there are very minimal secretions coming from the area, this will be removed gently by the nurse. So the drain will have a small suture holding it into position. This is removed by the nurse and the drain is then gently eased out of the area. I'm here to now talk to you a little bit about catheter care. A catheter is a small hollow tube that is gently placed into your bladder during your procedure. This is to drain urine from the bladder into a catheter bag. The catheter will have a small balloon attached to the end, which is inflated with saline during the procedure. These are generally painless and patients normally find that they get minimal discomfort. This is normally placed in situ at least overnight during the operation and then is gently removed by the nurse caring for you on the ward the day after the procedure. Sometimes we have to send you home with a catheter in place if you find it difficult to empty your bladder before being discharged home. If you are discharged from hospital with a catheter in situ, please be aware that this will generally be in place for a minimum of 7 days. The nurses that are discharging you from the ward will give you catheter care advice and supplies to take home, and then you will be seen in the community or with the specialist nurses at the outpatient clinic to have this removed at a later date. If you are struggling to get a date for your procedure to have your catheter removed, please be aware to contact your specialist nurse on the details given. So after your surgery, if you have any ongoing concerns, please do not hesitate to contact the urology nurse specialists. You will be provided with the telephone number to contact us on. Please be aware that we are available Monday to Friday, 8 till 5, excluding bank holidays. Concerning signs to look out for include worsening pain, that is pain that is getting worse rather than better. You should generally feel some discomfort after your surgery that may last anything up to 4 weeks. However, if the pain is increasing, you may need to speak to an out-of-hours doctor, your GP, or if this is acute, go to accident and emergency. If you have a fever, which is new to you, and you have got any signs of an infection or start with rigors, which are shakes, again, you may need to seek emergency care. Please be aware that a persistently discharging wound can be a sign of an infection, and you may need to see your GP for this to be examined, or contact the out-of-hours doctor, or again, accident and emergency if you are concerned. You may feel generally unwell for a few weeks after your procedure. However, if this is lasting and you are concerned, again, please get checked by a GP, out-of-hours doctor, or if this is worsening, accident and emergency. For more information, please follow the links on screen. If you have any ongoing concerns, please do not hesitate to contact the specialist nurses, and you will have been provided with their information at the start of your consultations. You will also be provided with the treatment summary by your surgeon, which will give you additional information in respect to your follow-up.